had a couple of questions on, and maybe all of you can deal with Medicare payments can address this for me. I asked CMS earlier today if there were any particular classifications of procedures that they automatically denied, because I hear that from my physicians at times, that they can file for a reimbursement for a procedure and it's just denied the first time. Then they have to go through this long process of waiting for them to be looked at again and going through the appeals process. But he said that CMS doesn't really just deny specific procedures, at least that's what I thought he said, but if they're coded wrong or if they think there's an excess of procedures done in one day that may not make sense, then they may deny them automatically. So I guess my question is, what percentage of your Medicare submissions for payment are denied? Is there a particular percentage that you see in your businesses? And if you could answer that one first of all.
We see probably about 5% of our claims that are denied. Being in oncology, we deal with a lot of not classified codes, which historically require additional information because they're just kind of generic codes at this point. The biggest part for oncology is, especially with the advent of the Genome Project and more specific diagnostic testing, is that we actually get a cocktail back from that testing that says this patient's DNA appears like it is going to work best with this combination of drugs. So we're fabulous. We're going to cut through the chase and get there. The problem is the combination of drugs that come back may not be FDA cleared for the cancer type that's been identified. We have federal regulation on our side to a certain extent that we can go ahead and create the medical necessary documentation, document it, work through that, but then we wait at least typically a year for payment. We go through the denial process because we have to tell CMS, I'm billing you off-label and I know that I'm billing it off-label so that we're not creating a fraudulent incident. So we inform them of that information. We go through a first level appeal. It's routinely denied straight up. Nobody even looks at it. We get to a second level appeal. Even if there is overwhelming documentation that we've met the federal criteria for the use of anti-cancer drugs off-label, it's historically denied again. Take it to an ALJ, and at that point, you're probably at a year out. I pulled my last ALJ. The service was for June the 7th, 2006. I won at July the 7th, 2007. We're not talking about a $10 payment. These cancer payments are depending on the drug, can be $20,000 for each visit. That is a lot of money for practice to loan out for 12 months to 18 months, but it's the right thing to do medically. So I think that's the precipice that physicians are at. The medical decision has been made, but can they financially afford to give the care? And they do have access. We look toward foundations to help ensure that we don't have to write a check for the drug, and we look to the drug companies for that information, but the patients have to financially qualify. So I think the technology has certainly outpaced the reimbursement stature where it's at, but that is the routine denial that our practice sees is truly the technology pacing and looking for additional guidance. I believe that Medicare is on the right track. They've expanded the credible journals that will be accepted. It used to be a very narrow list. The list is now longer, but still it is an extraordinary investment in time. And I think what's difficult and a learning curve that we learned at our practice is what you submit at your first level appeal is what you have to submit at the administrative law judge level. You can't add anything. So you know the first one's going to be kicked out, so you may not put as much effort because you're trying to get through the process. But once you forfeit payment on the first one, the administrative law judge says, so sorry, why didn't you give it to the first two? You lose it. So you figure out you have to do the upfront investment at the very beginning. So,
wow. Mr. Sherrod, do you have a comment?
Yeah, I have a couple. What's interesting is a lot of our patients are on immunotherapy, which is given skin testing or shots to help them out with their allergies. Well, when the patient comes in and sees a physician and gets a shot the same day, they reject the shot. And so what we do is we do a modifier 25 and they pay it. So my first question is, why? What's the difference between a modifier 25 or not? Just submitting it with, they saw the patient and the patient got a shot, so why are they rejecting it? Going back to your question, how many of ours are rejected initially? I'd be afraid to look because, I mean, we have 2 people full-time doing Medicare, dealing with Medicare patients. I mean, I'm sorry, the issues with the Medicare patients we see. Another one is, it's interesting, if a Medicare patient comes in and they get skin testing, and there's a couple sets, I'm trying to recall the name of them. It's, I want to say sublingual and intradermal. One of them, Medicare, only pays for 20 skin tests. The other one, they pay for 70. Well, what I got notified just recently, which you have to laugh about it, if we submit or do 21 skin tests, Medicare rejects the entire thing. Doesn't pay for anything. But if we do 18, they'll pay for 18. They do 20, they pay for 20, which I thought that was kind of interesting, and that's where some of our challenges are in play.
All right. If I could ask you one more question, too, about the length of time for processing these claims. I thought I heard some of you say that it takes up to 10 months at times or a year for some of the processing claims, once especially have been denied.
Right now, we're in May, and we're just still working on claims that were rejected in January. And some of them we cleaned up that were done in November and December.
Now, if they're not rejected, what's the length of time to get reimbursed on the Medicare?
19 days probably. It's a quick turnaround for our clean claims.
It is quick. Clean claims, yes.
Yes.
Now, if everything was electronic, what do you think your time payment would be? If everybody used electronics.
Well, CMS they're going to hold the claim for 14 days, and then, because we time how we bill, they hold it for 14 days. It goes to the banking floor for 2 days. You allow 1 day for transmission. So the best you're going to have is probably 17 days. So that's kind of how we typically see 19.
And if I could ask, Mr. Chairman, Ms. Nurse Deacon, if I could ask you a couple of quick questions. I think our bell's ringing for voting. In your testimony, you mentioned something about the state operations manual. How many pages are in that state operations manual?
My goodness. You know, I don't really know the count, but I can tell you it's that thick.
And how do you keep up with all the changes that are made?
That is an ongoing, if you do not pay attention to that manual and don't keep up with the updates, you're behind. And it's a daily chore for me. I am a small administrator in terms of numbers, so it's me. I'm the one responsible for keeping up with that. Some larger agencies have more staff that they can devote that time to. So it is a burdensome task for us, but it's absolutely imperative that we keep up with it. So I do it by email and just staying online with them and watching any of the information that comes out.
Do you ever find that there are any of the rules or regulations that might be more burdensome than they are helpful? And if there are, could you identify them and send them to us?
Oh, yes, ma'am. Yes, ma'am, to both of those. Yes, it's unfortunate, and I would say that we want to work with CMS. We don't want to fight with anybody. We want to take care of patients, and we want to do that the most efficient, effective way that we can, because the bottom line is who's out there may be your mother or your father or your sister at some point, and we want the best people out there taking care of patients, not being burdened with a lot of bureaucracy and paperwork that bogs us down frequently.
Now, I missed part of your testimony, but do you do telemedicine?
I personally, we make phone calls
firm?
to patients, but we do not have the monitors that I spoke about. Those monitors cost anywhere from $1,200 to maybe $2,500, depending on the elaborateness of that particular unit. So a little bit out of range for my size agency.
And maybe one of you can answer this, but is telemedicine reimbursable with Medicare? Because I know in rural Oklahoma...
It's not for home health.
I know in rural Oklahoma that telemedicine's a very good asset to be able to deliver access to care, especially specialty practitioners who might not get out into the rural areas, and just curious if that's reimbursable.
At this point, it is not. CMS encourages it. And even the quality improvement organizations that CMS designated to help agencies and other facilities become more efficient and work towards quality care, they've all encouraged the use of it. It's the cost factor that is prohibitive right now.